everybody. My name is Tina Bhutani. I am a board-certified dermatologist and clinical researcher practicing in San Francisco, California. I'm the CEO of Synergy Dermatology and also an associate clinical professor at the University of California, San Francisco Department of Dermatology. Today, I'm excited to be here to talk a little bit more about GPP, or Generalized Pustular Psoriasis. Even though this is a rare form of psoriasis that we don't often see, it's very important that we are able to recognize it and treat it quickly and efficiently, because it is one of the few true dermatologic emergencies. If a patient has uncontrolled GPP, they can end up in the hospital. They can have lots of downstream consequences, and there is a high mortality rate with generalized pustular psoriasis. So again, it's important that we diagnose and treat this disease quickly. Now, in the past, most of the treatments that we have used for GPP were kind of leftover, or I'd say trickle over treatments from what we were using for plaque psoriasis. GPP has always been put under the umbrella of psoriasis, and so we were kind of using those same treatments that we had for psoriasis for our patients for GPP. Traditionally, those were things like cyclosporin, acitretin used to be used a lot. And then more recently, in the modern age of treatment, we've been using a lot of our plaque psoriasis biologics, things like the IL-17 inhibitors, IL-23 inhibitors, TNF-alpha inhibitors for the treatment of GPP. And although they work most of the time, they are not very specific to the pathways that we know are activated in generalized pustular psoriasis. And specifically in GPP, we know that there is more activation of the innate immune pathways versus the adaptive immune pathways that are more active in plaque psoriasis. And one of the key cytokines that we know is involved in GPP is a cytokine called IL-36. So luckily now, more recently, we have an FDA-approved treatment specifically for generalized pustular psoriasis. It's not approved for plaque psoriasis. This is specifically for GPP, and it is a blocker of IL-36 receptor. So it's actually blocking the immune cascade that's activated by IL-36, which we know is critical in the pathogenesis of GPP. Data from the initial clinical trials has shown very quick efficacy. Actually, within 7 days, patients are able to clear their pustules in a large majority of cases. And we now have also long-term data to show that if a patient continues on the treatment in the long term, that they can actually decrease the number of flares that they're having over the course of a year. So not only is it great for flare management, but also for maintenance of disease in the long term. I've used this medication a few times in my clinic. I have a handful of patients who have GPP. I've used it both for new onset GPP. So I had a patient who came in with an acute flare. She was a young 35-year-old female, had never had any plaque psoriasis or any other skin disease in the past, and presented with now her second acute flare-up of GPP. The first time she had been seen was in the emergency room. She had been treated with antibiotics. It kind of partially improved her disease, and then she went, another 6 months before she had her second flare. That's when she re-presented to the emergency room, and this time got a referral to me as a dermatologist, which was great. And I was able to see her skin. We did do a skin biopsy, but it really was a highly clinical diagnosis. I diagnosed her with GPP, and we started her on Spesolimab. She had very quick improvement. She is a patient, because she's only had 2 flare-ups, we actually didn't put her on maintenance therapy just yet, because it's possible that she might not have a flare-up for a really long time. But if she does have recurrent flare-ups, then she would be someone that I would definitely treat her with sub-Q maintenance dosing to help decrease the number of flare-ups that she might have. We know that in GPP, the unpredictable nature of this disease makes it really uncomfortable and makes this disease have a high impact on quality of life for patients, because they don't know when their next flare-up could be. They get really nervous about it. So maintenance therapy for her could be an option in the future if she shows that she is having recurrent flare-ups. I also had another patient. She was actually a little older. She was 60 years old. She's had GPP actually for a really long time. I inherited her, after she'd had her acute flares. And when I inherited her, she was on a traditional psoriasis biologic. She was on secukinumab, and she was doing pretty good, but she still had occasional flare-ups, breaking through between her secukinumab shots. And she was actually a patient that I transitioned to just sub-Q spesolimab dosing for maintenance. I didn't have to do the flare management dosing for her, and she's now been flare free for over a year now. So again, she's a patient where we transitioned from an older biologic to a newer biologic specifically for GPP to get her skin under control. So those are just two clinical examples where I've used spesolimab in my clinic. There's lots of other opportunities to use this medication both on label and off label. It's being studied for things like pyoderma gangrenosum and other neutrophilic diseases. So it'll be exciting to see where the data shows in the future.